Good afternoon, sir.
Good afternoon. Good afternoon. How are you?
I am fine, sir. What about you? How are you now?
I'm fine. Everything is fine.
Okay, good to hear, sir. Uh, sir, Mehta sir will not join because of his father condition is not. He is admitted in hospital.
What
So
for?
Dr. Mehta sir will not join, sir.
What happened? What happened?
Actually, he is a 93-year-old sir, Dr. S.R.
Oh,
Mehta sir, na?
I
And
see.
he has a bilateral pneumonitis
Oh, I
and he
see.
is admitted in ICU. Oh,
Oh, then it's okay. No problem. You can take the class.
um, yes, sir.
Yeah. आनंद,
जी गुड आफ्टरनून सर।
गुड आफ्टरनून। क्या हो रहा है?
जी बस बढ़िया सर। सर ज्ञानंद तो सर आप म्यूटेड है सर, अनम्यूट कर लीजिए अपने आप को।
हम तो अनम्यूटेड है?
नहीं ये ज्ञानंदू सर को बोल रहा है।
वो अच्छा अच्छा अच्छा। उनकी आवाज तो हमने सुनाई दे रही थी, लेकिन
दरिया सर थे, दरिया सर थे।
वो अच्छा उधरिया सर थे। हाँ,
जी जी जी।
और तो इनको अनम्यूट कराओ। हाँ,
Am I audible? Good afternoon, sir.
हेलो, गुड आफ्टरनून, गुड आफ्टरनून।
I'm audible now. It's okay.
ये ऑडिबल एंड भेजबल बोथ।
Thank you, sir.
थैंक, गो अहेड।
Okay. So, should I start, sir?
यस यस यस।
Good afternoon, seniors, respected seniors, my dear friends. We are here to discuss about celiac disease. Many things from myth to reality. What celiac disease is? First question arises, what celiac disease is? Actually, it's a chronic small bowel diarrhea of immune mediated origin with a very strong genetic predisposition. Every word has its very impactful meaning, because whenever we discuss about chronic diarrhea, it's a diarrhea of 4 weeks, more than 4 weeks duration. Again, diarrhea has been divided into, according to location, a small bowel diarrhea or large bowel diarrhea. Celiac disease is basically a small bowel diarrhea, which is very much notorious for its malabsorption pictures. And here, immune mediation is the most important thing. And this immune mediation is almost like an autoimmune disease, where antibody mediated damage due to food allergy, particular food allergy, occurs to mucosa of the small bowel. Then thus it's a mucosal disease. And immune mediated with a very strong genetic predisposition, that whenever we see in a pedigree or in a family analysis or family history of a celiac disease patient, we usually found it in 8 to 18%, almost 10% of patients having a first degree relative with this disease. Even HLA studies were done, and it was found a strong HLA association where HLA DQ2 was found to have positive in 90% of cases, and HLA DQ8 almost 9% of cases. Even for first degree relative, concordance rate was even seen very high in identical twins even. Then pathophysiology, if we discuss about pathophysiology, then this immune mediated damage usually in submucosa, in lamina propria, usual cells are T helper cells, and some enzymes, those are destined to work on the tight junctions, endomysial smooth muscle cell around. Antibodies are formed against these enzymes. Whenever a trigger point, a trigger food, particularly here is the protein, gluten component of the protein. Gliadin is a wide term where glutenins and proteinins, two types of proteins are there. Gluten is a non-water soluble protein. It's an alcohol soluble protein, which is here is the culprit for the food allergy, which is a very absolute allergy, where even a smaller particle, 20 particles per million, can be responsible with this drastic absolute allergic event. Then antibodies formed against those destined enzymes, destined locations, destined tissue parts that causes the damage of the intestinal mucosa. Again, we have discussed about things, and the most important food particles in which gluten is in abundance with hierarchy, we will go through. First is wheat. Wheat is the most notorious thing that causes gluten sensitive enteropathy in those genetically predisposed patients having this with the very strong immune mechanism. The second one is barley. Third one is rye, and the fourth one is oat. Oat is having a very small, minimal amount of this gluten in their food. That's why oat has a very minimal incidence of celiac disease, but it has been found strongly correlated. Next slide. Coming to frequency of this disease, a lot of studies were done about the incidence rate, frequency, and even male to female ratio. It was very much predominant in European country, in Mexico, in America, where this food revolution has started from, and highest prevalence was seen in these European emigrated persons in North America and Australia. Coming to India in Asian population, and particularly we are Indians, that's why we will talk about India first. Wheat eating population, particularly in 4 states: Rajasthan, Haryana, Punjab, and the nearby Delhi. These 4 places are having maximum incidence of celiac disease. I have been a pass out of Jaipur. I did my DM from Jaipur, and out of 3, we were getting 1 cases of celiac disease out of 3 malabsorption syndrome we used to see. Even atypical celiac disease, we will discuss about what typical celiac disease and atypical celiac disease in a couple of minutes. In atypical celiac disease, where symptoms are not of particularly of a chronic diarrhea, these are very subtle symptoms. Patient usually presents with features of anemia, iron deficiency anemia, unexplained pain abdomen, and even constipation, which is a very drastic and opposite event of a explosive chronic diarrhea, a small bowel origin diarrhea. Here, patient presents with constipation. Even atypical symptoms were very much prevalent in Rajasthan. Next slide. It can be seen in first time in any part of life. it has a bimodal prevalence, a bimodal predisposition. At one spectrum, we used to see when food is introduced in a child, first time after weaning from breast milk, when food is introduced, that is the one age where usually child presents. Another age in adulthood or adolescent youth, and this is the most common population among which celiac disease has been found. And even it was found that 25% of cases, one-fourth of cases, occurs after 60 years of age. This is a very, very incredible and very wonderful things. Even after 60 years of age, we used to find one-fourth of cases of celiac disease that occur all at a sudden. This is the, notoriety of this immune-mediated disease. A trigger point, immune-mediated damage can occur at any junction, any time of age. Next slide. As we have already discussed, it's a very strong hereditary component. I have talked about DQ2 and DQ8 HLA association, where DQ2 HLA association is very strong. And first degree relative, we have already discussed, it's 8 to 18%, almost 10% of patient. And we have discussed damage to the intestinal mucosa with antibody triggered by this gluten component in the food. Next slide. One thing we have left, there is a slight female preponderance in celiac disease. Earlier in the previous studies, it was found female to male ratio was 2:1. Nowadays, with most of the studies have agreed around it comes around 1.3:1. Thus, there is a slight female preponderance here. Next slide. How does gluten causes negative effect? These proteins are rich gliadin peptide fragments, survive the digestion process in the gut. And these peptides are demediated by tissue transglutaminase. These are the enzymes. Usually these are present in mucosa. 6 types of tissue transglutaminase enzymes are there. Usually type 2 tissue transglutaminase enzyme we used to see here as a culprit in celiac disease. This is a CD4 T cell mediated immune response. Thus, it's a T cell mediated, helper T cell mediated immune response. Next slide. Next slide. We will discuss treatment later on. Risk factor. What is risk factor? Already we have discussed. It's genetic predisposition is a very strong thing, and immune mediation. Thus, being an autoimmune disease, it is very difficult to say when will an autoimmune disease will begin or start. It may occur at any juncture of age, any time of life. Association is very strong with other autoimmune diseases, type 1 diabetes, with hypo and hyperthyroidism, both rheumatoid arthritis, juvenile rheumatoid arthritis, Sjogren's syndrome. These are even microscopic, coming to GI diseases, microscopic colitis, collagenous colitis, eosinophilic enteritis. These are the associations which are strongly associated with celiac disease. Next slide. We have already discussed race, European, American, Asian. Sex incidence we have already discussed. Age, I have already discussed the bimodal distribution. First 8 to 12 months where food is introduced in a child, it is food. And the second, third to fourth decade, which is the most common age group in adulthood. Next slide. Italian race has been found something more, some incidence is more in Italian. Some theory were given with repeated recurrent rotavirus infection in infancy, but it has not been proven. It has been not more than a myth. Next slide. Coming to histology, what exactly occurs in celiac disease? As we know, it's a malabsorption syndrome. Malabsorption, wherever we talk about malabsorption, there must be deficiency of two or more than two micro or macronutrients. This is called malabsorption. It's a malabsorption syndrome. Then histological changes that occurs that causes difficulty or disturbance in absorption of the nutrients from a small bowel, and that histological changes are partial or total villus atrophy. We know villi are responsible for the absorption, and intestinal mucosa is a columnar epithelium. Villi, and over the surface of villi, almost millions of microvilli are there, and these are the structures which are responsible for absorption of different nutrients after their digestion in the gut. Due to loss of this villi, according to the severity of the disease and extent of the disease, loss of this villi occur, villus surface area is decreased, and thus malabsorption occurs. And the concurrent features that occurs, it's a series of events. First is infiltration of, first is called pre-infiltrative stage, where infiltration of submucosa, lamina propria with inflammatory cells is increased. Plasma cells is seen, intraepithelial lymphocytes is seen in increased amount, T lymphocytes are seen. Actually, on the basis of these intraepithelial lymphocytes and damage of the mucosa, classification, histological classification of celiac disease has been done, that is used for its diagnosis. Mars classification and modified Mars. We will discuss this later. Next slide. This is the microscopic pictorial diagram, microscopic picture of the celiac disease, where a difference between normal, left side is normal one and right side is abnormal one, where the columnar epithelium surface is having mucosal depletion, where almost flattened mucosa is there, loss of villi is there. Next slide. These are again a enlarged picture with more than 100 times magnification. The surface area, the mucosal surface and villus surface is decreased. And here in one picture, it appears on the right corner, there is crypt hyperplasia, which appears in the picture. Next one. Coming to symptoms and signs, what exactly clinical features are there? Here we will discuss the earlier said thing. There is two types of celiac disease according to sign and symptoms the patient present with. First is typical celiac disease or classical celiac disease, it is called, where the patient presents with a picture of a chronic, a small bowel diarrhea with features of malabsorption. Here diarrhea, steatorrhea, appetite loss, weight loss is the predominant picture. And the second one is, I have already discussed, that is on atypical celiac disease, where presentations are subtle and they are very much atypical other than diarrhea, where pain abdomen is rampant, where unexplained anemia is iron deficiency, anemia is very much there, and even constipation is seen in those patients, atypical celiac disease. Thus, when we talk about celiac disease with chronic diarrhea, malabsorption of those things occur that are done in that are being done in gut in small bowel segment. We divide a small bowel segment into proximal segment and distal segment. In proximal segment, absorption of iron occurs, calcium occurs, and folate occurs. And in distal segment, terminal ileum, vitamin B12, and bile salt and bile acid are basically absorbed. Next slide. This is a typical picture of a child in celiac disease having a protuberant abdomen and less turgor of the skin, loss of muscle mass. Next slide. Next one. Again, when we discuss about the symptom of this disease, so the symptoms present due to deficiency of this iron in the proximal segment, calcium, folate, here iron, and in extreme cases, dimorphic anemia due to vitamin B12 and folate deficiency has been seen. IDS is the most common thing, iron deficiency anemia. Rickets has been seen in children at an early age due to deficiency of calcium and concordant deficiency of vitamin D due to and many presentation of many signs due to this symptomatic changes. Pallor will be present due to deficiency of vitamin B12, hyperpigmentation of body or particularly of extremities are present due to deficiency of calcium. Again, rickets and adulthood osteomalacia or osteoporosis pictures of are seen due to deficiency of protein and albumin, edematous body, edematous less turgor of skin, and loss of muscle mass was even found. These are the signs usually. Even in cases of deficiency of fat soluble vitamins A, D, E, K in extensive celiac disease where involvement of small bowel is extensive, almost terminal ileum is involved. When terminal ileum is involved, we used to get deficiency of vitamin B12 and fat soluble vitamin A, D, E, K. In those cases, again D is deficient. A, night blindness will be seen. With D, we have already discussed many bony changes. With deficiency of vitamin K, EG bruising, ecchymosis will be seen. It will be a very important sign in that extensive disease cases. Next one. Already we have discussed things: weight loss, fluid retention, anemia, osteoporosis, early bruising. Yeah, peripheral neuropathy. Neurological signs and symptoms are very much common, and the neuropathy is top amongst them due to deficiency of vitamin B12, folate, and other like thiamine, other pyridoxine deficiency. In extensive advanced cases of vitamin B12 deficiency, we used to see pictures of ataxia, where posterior column, where spinal cord is involved and posterior column is involved, we used to get ataxia. In rare neurological involvement, rare neurological cases, even unexplained idiopathic epilepsy, seizure disorder is seen. And these seizures are of particularly complex partial seizures. On CT scan and MRI, sometimes we used to get some peculiar calcification in parieto-occipital region of brain in celiac disease. Again, hormonal changes, developmental changes are very much common in male children occurring before puberty. Loss of secondary sexual character or delayed development of secondary sexual character, infertility is there, impotency is there in male. In childhood cases, again, growth retardation, stunting of growth and wasting is seen. So in children coming with growth retardation, it's very important to take history about food allergy, and celiac disease is one of them. We must consider celiac disease a factor very important in evaluating growth retardation. Muscle weakness we have already discussed, neurological things we have discussed. In female, due to early deficiency of due to early absolute allergy, early celiac disease, again secondary sexual characters are delayed in development. Menarche is delayed, onset of menstruation is delayed, and in female of reproductive ages, libido is there. Infertility is quite common. Recurrent stillbirth is common, or it is one of the case of spontaneous abortion. These are common finding in female, young female, reproductive age female having this celiac disease. Next one. Next slide. Yeah, coming to skin manifestations. We have discussed hyperpigmentation, we have discussed ecchymosis, we have discussed pallor. Again, a very important skin disease which is associated with celiac disease is dermatitis herpetiformis. What is dermatitis herpetiformis? Usually we see papillovesicular rashes in this disease. These papillovesicular rashes are there in extensor surface of body, particularly in limbs, buttocks, trunk, and these are very itchy. These structures are very itchy. And why it occurs commonly in celiac disease? What is the basis of the association? The basis of the association is the same enzyme, tissue transglutaminase. Here, tissue transglutaminase enzyme type 3 is responsible, and which is again found in epidermal surface of the skin. So, in almost 8 to 10% of cases, almost less than 10% of cases, sometimes we used to get this skin manifestation, either in our practice or sometimes it has been detected first in skin OPD, and from there that case has been sent to us for evaluation, further evaluation. Next slide. Dental enamel hypoplasia due to deficiency of calcium, vitamin D, these permanent dentition, early shedding of teeth is there. Next one. We have discussed about short stature and delayed puberty. We have discussed about growth retardation in the children. It has to be evaluated very much with this gluten sensitive angle. Adolescent girls, I have already told about, there is delay in onset of menstruation, that is menarche, and in female, young female of reproductive age, there is it's a cause of infertility and recurrent abortion. Next one. Yes, arthritis and arthalgia. Arthritis can be a common extraintestinal manifestation of adult with celiac disease, and it has been found in 3% of children having juvenile type of chronic arthritis, rheumatoid arthritis. These are associated with celiac disease. Next one. Psychiatric disorders. Usually, intelligence is preserved in celiac disease. There occurs very little effect on maintenance, mentation. Intelligence is very much good. The child IQ is very much good, but some psychiatric problem with the loss of or severe, with the presence of severe anemia, pictures of nutritional deficiency occur. These are usually with anxiety or depression. Mood swings are there, but other than that, there is no behavioral or cognitive or any other psychiatric differences in a celiac disease child. Neurological we have already discussed. Here intelligence and IQ is very much preserved. Next one. Coming to diagnosis, very important thing, how will we diagnose a case of celiac disease? It's a very much dependent on a good history, prolonged history, examination of the patient, further investigations, first serological investigation, and the second one is the confirmatory gold standard investigation, that is endoscopy with duodenal biopsy, D2 biopsy, where D2 or D3 biopsy, and confirmation and diagnosis is made on the basis of that. First thing is history. Again, with a typical presentation, a patient usually comes with a chronic diarrhea, a small bowel origin. What is the difference between a small bowel and large bowel origin? Diarrhea. A small bowel diarrhea are less in frequency, usually 3 to 5, maximum of 6 duration. Volume is large volume. What is large volume? Usually a patient used to say वो जितना खाता है उससे ज्यादा ही उसको स्टूल पास होता है. This is the best, subjective or best objective. I think it's an objective parameter to say it's a large volume diarrhea. Large volume diarrhea and frequency is less. In large bowel diarrhea, having rectal symptoms, the frequency is very much more than 10, 15, 20 associated with mucus discharge, associated with blood discharge. The urgency is there, tenesmus is there. These are the differentiating picture of a small bowel diarrhea, and then the patient present with chronic small bowel diarrhea. Then we look for features of malabsorption. Is there any pallor, presence of pallor? Is there hyperpigmentation? Is there we will discuss it here. Decreased size of a spleen. Is there any other skin changes? Is there dermatitis herpetiformis? Is there associated other autoimmune disease? We used to examine patient in our OPD or in hospital. Then the serological test. Next slide. We have already discussed these things. Physical examination finding. Next one. E.g. bruising and loss of sensation with presence of neuropathy. Sensation is loss or decrease in extremities, including vibration, position, light touch due to vitamin deficiency. Severe vitamin and mineral deficiency, deep tendon reflexes and muscle spasms are there. Yes, next one. Coming to serological test. What blood investigation we must proceed with in these cases? Here, very important, two things are very important. What are the most specific tests? Endomysial antibody. Endomysium is the innermost portion of the smooth muscle. It's called endomysium. Anti-endomysial antibody and TTG, tissue transglutaminase enzyme level. These two antibody against these two entities are the most specific one. Almost a specificity in 98 to 100% in EMA group and 97 to almost 100% in TTG. But EMA are usually of research-based things, and it takes time to evaluate and report an EMA. Thus, TTG is very much popular nowadays, and it has a very good sensitivity, almost parallel with specificity, almost parallel with EMA, and sensitivity almost equal, almost totally equal to EMA. Here we used to see IgA antibody level. Why IgA? Because IgA is present in gut in abundance. It's a secretory antibody, and it is been found to be protective one in our gut. IgG level is not taken in cases for diagnosis until unless there are some selective IgA deficiency. Here we discussed something about immune deficiency disease. Common variable immunodeficiency disease is the most common type of immune deficiency disease, where all type of immunoglobulins are less in quantity, less information, IgG, IgA, IgM, all. Yes, selective IgA deficiency cases are here. 5% of all immunodeficiency disease having this selective IgA deficiency taken together. In 5% of cases of immune deficiency disease, selective IgA is there. Here, IgA level is a false one. When we use IgA TTG level or IgA EMA level, and patient having earlier a selective IgA deficiency, it will come blue, and the diagnosis will be in difficulty if we take here. Here, DGP level is taken, deamidated gliadin peptide antibody level is taken, in which IgG and IgA, both type of DGP has been done. So that when we strongly suspect a person, a child, we first screen it out, and the screening tests are antibody to TTG level. And when we suspect where IgA level is already low, where it can be low, we proceed with TTG DGP. TTG DGP, a combination where DGP level is seen, IgG level is seen there, and DGP is raised in those cases. Again, here a very, very important term is there. Non-celiac gluten sensitivity. Here, one terminology is there which comes out in light. Non-celiac gluten sensitivity. What is non-celiac gluten sensitivity? In non-celiac gluten sensitivity, food allergy is similar. Gluten, a person is sensitive to gluten, his gut mucosa is sensitive to gluten, similarly like in celiac disease. But the typical pathophysiology of celiac disease is not there. Thus, immune-mediated damage to transglutaminase or to endomysium is not there. So these antibodies are negative, but gluten sensitivity is already there. These cases are called non-celiac gluten sensitivity. Next one. When we find in screening test positive, usually the upper level of threshold of the IgA TTG is 20 AU per ml. When we use to somewhere it is around 15, but above 20, it's positive. When we used to get this positive result, there comes the term of a confirmatory and gold standard test, that is endoscopy with duodenal biopsy. When we plan for endoscopy, we used to reach by endoscopy in the second part of duodenum, from second part of duodenum, and even from deep third part of duodenum, multiple biopsy, small bits of mucosal tissue is taken. Almost 6 to 8 is recommended, and to compare it with normal mucosa, at least a single bite of duodenum type 1, D1, a bite from D1 is also taken. Next one. Again, these biopsy samples are sent to histopathological study to a good pathologist, and we have already discussed what a pathologist see in their finding. They used to see the level of infiltration of different cell in lamina propria, in submucosa. They used to see the level of crypt hyperplasia in the histopathological specimen. They used to see level of villus atrophy. Either it's a partial or subtotal villus atrophy or total villus atrophy in the segment. According to Mars classification has been done, where 0 is the normal, 1 is the pre-infiltrative stage where infiltrative cells are there, 2 is again only crypt hyperplasia is there, villus are intact, and 3 is subtotal or partial villus atrophy, and type 4 Mars classification is total villus atrophy. Again, a modified Mars classification has been added to it, and the additional feature was presence of intraepithelial lymphocytes per 100 enterocytes has been added. It has been found in early Mars classification or pre stages 0, 1, 2 intraepithelial lymphocyte is less than 30 per 100 enterocytes, and type 4-5 modified Mars classification. Other than the previous Mars one, intraepithelial lymphocyte is more than 30 per 100 enterocytes. Next one. Next one. We have already discussed the microscopic finding. Next one. Here we will discuss some protocol of treatments. What about in a diagnosis in a kid, in a child, even a child of 3-4 years, less than 5 years? Usually we used to follow here. Some criteria has been given by European Association of Pediatric Gastroenterology, ISAFGAN criteria, North American criteria of NASAFGAN criteria, American College of Gastroenterology criteria. We used to follow ISAFGAN criteria, where it has been said that if level of tissue transglutaminase enzyme IgA TTG is more than 100 or more than 10 times of upper limit of normal, there is no need of biopsy or no need of endoscopic duodenal biopsy in the children. This should be straightforward termed as a case of celiac disease, and not enforcing those children to the invasive endoscopic procedure, and straightforward they can be started on gluten restriction and gluten-free diet. Then treatment, again, we have to avoid. This is an absolute allergy. So absolute restrictions of gluten is needed. Wheat is must be totally restricted. We used to write on our prescription, गेहूं का बना सामान, आटा, मैदा, सूजी कुछ नहीं लेना है, बाहर का ब्रेड, बाहर की बिस्किट कुछ नहीं लेनी है, even sweets from outside we totally prohibit, because for condensing maida or this refined flour has been added to those sweets. Even the level of intensity of allergy is so much there, 20 particles per million can be a cause of this absolute allergy. So we used to say, even change the utensils, of the patient, his thali, his glasses, his cooking utensils must be changed. Next one. Thus, complete elimination of gluten containing diet, maximum wheat. Second one is barley, third one is rye, and very minimal amount of oat. Next one. Avoid the gluten. We have to, put the patient on absolute gluten-free diet. Either he must make his flour by his own, using maize, using refined pea flour or sattu, or the millet, different millets, or he must purchase a GFD atta, GFD flour from market, gluten-free flour. Next one. Next one. Again, this gluten-free flour, gluten-free atta is very much available in market. In our part of state, it's very difficult to find a good store having gluten-free diet, but online it's available on online. But we were getting, especially gluten-free stores where gluten-free biscuits, gluten-free diets, gluten-free atta, gluten-free, everything was available in Jaipur, Delhi, in bigger cities, in metro cities, these are available. Next one. Corticosteroids. Do corticosteroids have any role in celiac disease? Absolutely not. In common cases of celiac disease, steroids are used, but in few cases where it is called celiac crisis, or very explosive diarrhea occurs with features of nutritional deficiency and dehydration, with features of dyselectrolytemia, which is not responding to early gluten restrictions and different treatment. Here, steroid can be used as an adjunct or on trial basis. This is the only indication of steroid in celiac crisis, what is called celiac crisis. Otherwise, corticosteroid has no role in celiac disease. Next one. Here we will discuss, before closing this talk, we will discuss some type of modality of treatment which has been tried. First one was some intranasal inhalational spray that acts against IL-15 immunotransmitter, IL-15 cytokines. Larazotide acetate was a drug which was earlier used, but again, nothing was proven. Some treatment modality as under pipeline, some Z101 disease, TD1022 molecules has been named, and studies are going on with them. But again, chances of these studies to be very fruitful and result oriented is very difficult. Here, we must rely on absolute restriction of gluten, and that we have to make sure compliance is very much maintained. Compliance is a very important thing. Whenever a patient comes to us and say, yes, I'm on totally gluten-free diet, first thing we inquire about his symptom. What about the frequency of stool? What about the frequency of diarrhea? If it comes around something positive, we will see the TTG level. That TTG level in retrospective, in retrograde, say about the compliance of the patient. If it is elevated, that means total gluten restrictions has not been done judiciously or religiously. He must be taking, mistakenly or by default some amount of gluten. That I have already said, even 20 particles per million gluten, if going in a patient, allergic symptoms, sensitivity, and enteropathy must be there. The first thing is, and foremost thing is, absolute restriction for patient to be put on absolute GFD gluten-free diet. With that, I conclude my talk. Thanks to all senior members, Dr. Kamlesh sir, and everyone present.
Thank you. Thank you, Dr. Gyanendu, for a wonderful lecture.
Thank you very much.
Thank you, Dr. Gyanendu. We have Dr. Daria. Dr. Daria, I would request you to kindly sum up the whole session. And if we have any questions, please write in the chat box so that we can request Dr. Gyanendu to answer those questions. Dr. Daria, please.
Thank you so much, Dr. Gyanendra, for a wonderful session. That the topic is very easy, that celiac, but after listening 1 hour, you clarify everything regarding the celiac disease. So it's a wonderful session. A few questions comes in all residents' mind or some patients also. Like if somebody, today only we diagnose one patient as a celiac, but that patient came for the CLD. Okay. Patient came with the complaints of your CLD picture. Then we did the upper GI. There was a esophageal varices. Then in there is EPHVO, but there is no symptoms of that celiac disease. Okay. So in that case, we found that TTG is 140. Okay. So should we give gluten-free diet in those patients who are asymptomatic?
Absolutely, sir. Now, in protocol of etiological diagnosis of CLD, the celiac disease has been included. I have forgotten to mention this. In etiological diagnosis of CLD, celiac disease has been included very much nowadays. in all idiopathic cases already, it was called idiopathic CLD, idiopathic cirrhosis. Nowadays, IgA, TTG level, and if needed, duodenal biopsy and endoscopy is done. Thus, celiac disease, one of the case of CLD, one of the cause of CLD is noted very much today. And even in celiac disease cases, EHPVO, extrahepatic portal vein occlusion, EHPVO is quite rampant. EHPVO and NCP, both the entity, NCPH are quite rampant.
Your question, Dr. Daria was asking. So these are basically asymptomatic celiac disease patients.
Yes.
So should we request these people to have the dietary
Gluten-free diet.
restrictions?
Because here the mechanism is the same. Absolute allergy, food allergy, sensitivity that causes destruction of hepatocellular dysfunction and hepatocellular destruction. Here, chronic diarrhea is not there. It's an atypical symptoms almost. This is the part of atypical celiac disease. Food restriction must be there in those patients also.
Okay, thank you, Doctor. Thank you, Dr. Gyandu. There's a question in the chat box. Daria, please.
Yes, sir.
How to
okay,
differentiate from IBS if no malnutrition is there in celiac disease?
Again, with IBS, patient has a long symptom. Features of malabsorption is almost not there. No weight loss, no appetite loss. Their psychiatric symptom, behavioral symptom will be predominant. Anxiety, in one spectrum, anxiety will be there, and depression is there. And very explosive symptoms are never there in IBS cases. Whenever we compare with IBS, diarrhea predominant IBS, IBS-D, and celiac disease. Usually they are very much subtle with no features of malabsorption. In celiac disease, might be explosive symptoms with features of malabsorption, iron deficiency, anemia, and other things. Other deficiency will be very common.
Thank you, Dr. Nandu. Dr. Daria, please.
Yeah. As we see that in the type 1 diabetic patient, there is a strong association with the celiac disease. But initially what happens, we used to diagnose in a type 1 patient is early age of like 2, 3 years, 4 years in. Patient is already asymptomatic regarding the celiac disease. But once in the age of 13, 14, 15, we generally used to go send for the TTG. Okay, that comes positive. So why it happens that patient of type, it's a very, very strong correlation between the type 1 and the celiac. But patient did not through the symptoms of that celiac.
Symptoms usually in type 1 diabetes patient, usual presentation of celiac disease or this gluten sensitivity occurs in adolescent age, usually in adolescent age. Usually we detect them in adolescent age or adult. First thing, the association is very much strong. We have to look if there is a strong genetic predisposition, if there is a family history, we must do it with HLA estimation at an early age, so that we must restrict gluten at a very early age, even if he is symptom free.
That's good, sir. For just my curiosity, what happened? I diagnosed type 1 patient with the celiac, okay? But I thought I should do something, then I did not stop the gluten. I kept on continuously gluten diet, and they were absolutely all right for 5-6 months. But after I thought if it is a positive, then I started with the gluten-free diet. So why it happens?
I did not get the question. After 5-6 months.
Sir, celiac disease patients, I did not kept on gluten-free diet. Okay, I kept on gluten diet continuously, but there were no symptoms. Patient was all right even after
these patients. So, Dr. Daria, what I can perceive is your question is why do those people of type 1 disease become symptomatic late?
Yes.
Do they
Yes.
even if they have those genetic predisposition and genetic markers positive, antibody positive, still they are not asymptomatic? Why? What is the reason of not being asymptomatic in these patients, Dr. Gyanendu?
We had this appreciation that there might not be in all celiac disease presentation of diarrhea or steatorrhea is necessary. Again, we have already discussed atypical symptoms are quite common. In those patients, only anemia will be there, an unexplained pain abdomen may be there, even constipation may be there. I have seen a few cases of type 1 diabetes with celiac disease. Constipation is a very predominant symptoms. I usually find in those cases with having a type 1 diabetes mellitus, predominant GI symptoms are subtle. And why this is so, it's unexplained till now, I think. But atypical symptoms are predominant in type 1 diabetes mellitus, in those patients with celiac disease with type 1 diabetes mellitus.
Okay. There is a question of role of sporolac in celiac disease.
I did not get it.
Role of sporolac. I think it's a prebiotic in celiac disease.
No, not studied, not significant. Like in a placebo. Nothing significant.
Okay. Yeah,
Okay,
Dr.
you said that the TTG level is we can use as a marker. Patient is taking the gluten-free diet, yes or no, right? So if it is increasing again, that means patient is not on
Yes.
the gluten-free diet.
Very important marker for compliance of the gluten diet. If a patient is put on gluten-free diet and he comes and say, yes, I am taking a very strong gluten-free diet, and we used to get first thing we used to ask about his history, stool frequency, stool consistency, or even if it is normal. When we used to see screening test of IgA TTG, and if it is increased, that means first thing is non-compliance. There must be non-compliance. It has to be taken first in account. And the second one, I have not discussed because these were things in detail, refractory celiac disease. And another term, RCD, is there, type 1 and type 2 RCD, refractory celiac disease. We have to consider with development of advanced complication of celiac disease, like ulcerojejunative ileitis, a very important thing, and development of T-cell lymphoma, EATL, enteropathy associated T-cell lymphoma has to be kept in mind, where a patient is on absolute GFD, gluten-free diet, and despite that, he is symptomatic with diarrhea or with atypical symptoms or with rising IgA TTG level. This must be kept in mind. There must be refractory celiac disease, non-compliance, and development of advanced complication of celiac disease.
Yes, sir.
So those were very good questions coming from Dr. Daria and well answered by Dr. Gyanendu. These are some of the practical tips which young students who have joined might get benefited. So if there are no more questions, Dr. Daria, can we end this session?
Yes, sure, definitely. Dr. Gyanendra, you when you were in SMS, Jaipur?
I was there in 12 to 15. 15 I passed out 10 years back. I was there
because
12 to 15.
Because
I think
I was there from 11 to 24th in medicine.
Yes.
okay.
So I think you did after Dr. Jhajaria, right?
Yeah. I'm junior to Dr. Jhajaria, 2 years junior to Dr. Jhajaria.
Rajmani batch mein.
Rajmani
Rajmani must be there.
to me.
Okay.
Senior to me.
So let the friendship continue even after the meeting.
Yeah.
So thank you, Dr. Gyanendu, for a wonderful lecture at a very short notice on celiac disease. And thank you all participants for being here in the short certificate course Hematology division. And thank you, Dr. Daria, for holding the program well together. Thanks goes to Dr. Sudhir Mehta sir for this wonderfully conceived hematology class, and lots of thanks to Dr. Kamlesh Tiwari for conceptualizing this short certificate course, and the Indian College of Physicians for allowing this program to be conducted across the nation. Thank you, friends. We meet again next Tuesday. Thank you very much.
So much. Thank you so much, Dr. Amit. Thank you.